In general, people are giving the prophylaxis, but in terms of the prophylaxis, there a controversy is there. In the majority of the cases, the autologous transplant, you are using the ciprofloxacin or the levofloxacin prophylaxis. Sometimes you can use the other antibiotic also for the prophylaxis, but giving the prophylaxis, there is a debate whether we can give the prophylaxis antibacterial to reduce the infection is there or not. There is a concern in terms of the treatment, but in terms of the after the engraftment, there are two important things is there that to prevent the encapsulated organism, to prevent the pneumocyte GRBC, the co-triamoxial prophylaxis has to be given each and every patient. In terms of the antifungal prophylaxis, there is a clear-cut recommendation by the given that the ECL 2018 that in terms of the pre and the post-engraftment period, we have to be given the prophylaxis. The fluconazole has to be given. In terms of the GVHD, the spironolactone has to be given. This has been given the A1 recommendations by the ECL group. This antiviral prophylaxis has to be given each and every transplant period. So, ladies and gentlemen, the take-home message of the infections in the transplant that the infection pathogen and the infection syndromes is different according to your different phases of the transplant. In terms of the pre-engraftment period, the neutropenia is the major concern. Febrile neutropenia has to be seriously taken care of that, otherwise you can lose the patients. If the patient presented with the pneumonia, you have to look for the nodular infiltrate and the diffuse infiltrate. Depending upon that, you have to play around it. In terms of the diffuse infiltrate, the non-infectious cause, the post-transplant has to be a major concern. In terms of the early post-engraftment period, the pneumonia, either it can be infection or it can be non-infectious cause, that has to be clearly balanced. In terms of the late post-engraftment period, particularly the sinopulmonary infections, and especially the chronic GVHD patient, there is a chance of encapsulated bacteria, the pneumococcal, there is other infection is there, you have to be taken care. And the varicella zoster, the herpes zoster is become notorious, particularly in case of the late in terms of the stage transplant. So the infection identification, the management and the prophylaxis, you should be master for doing this transplant. So I am again repeating that by putting a conditioning regimen, by giving a stem cell graft is nothing, but managing the infection is become major concern. Then only you can improve the survival of the patient with the transplant. With this, thank you very much for the patient hearing.
We're taking two questions from the audience. Yes, sir.
Sir, thank you for an exhaustive talk and extensive talk. Sir, my question is, sir, is there any place for surveillance culture before I start my empiric therapy based at an institution?
So I think this is a very important question. The people are sending the survival culture. There is a different center they are following routinely. But if you go to the science of the survival cultures, in terms of the survival culture, people is not in favor of the routine surveillance culture before the transplant. Because you already know your the local pattern of your antibiotic resistance and your the chance of infections. Depending upon that, you have to choose your antibiotics. So in terms of the surveillance cultures routinely, we are sending the stool culture, the urine culture, the pre-transplant, the surface culture, there is a pros and cons is there, but the majority of the center, they are not in favor for the surveillance culture.
And any role of trains in CRP to monitor the infection?
This is also another important, the critical question. The some center, they are following the CRP as a screening tool and also the monitoring tool. Our center is also following, the other center is also following. Yes, there is some role is there, but there is a lot of pros and cons is there, particularly in case of the CRP. CRP is not only elevated in terms of the infection, but it can also range in terms of the inflammations. If you have an inflammation, because the transplant, the post-engraftment, apart from the infection, the inflammation is also very important. So in the post-transplant period, only CRP monitoring sometimes becomes falsely impressed that my patient is become suffering from the infections. Because GVHD itself is an inflammatory process. So in that situation, your CRP might range. So the CRP equivalent to the antibiotic is not.
Yeah, I have a question. If any patient is allergic to that, so what
I think yes, this is very also another important practical question. If the patient has a so in that situation you can sometimes use the other drug, sometimes there is a nebulization forms of antibiotic is there, sometimes people are using the atovaquone, sometimes the people may are giving the dapsone, there is a lot of the other options is there, sometimes they are giving azithromycin also. So there is a lot of the options is there, you can use it, but the septal prophylaxis, majority of the cases has to be used. There is a chance of yes, allergic infection, sulfur allergies, 5 to 10% cases is there. So in that scenario, you have to manage very judiciously with the other drugs.
Okay, Dr.